There's a moment that happens to almost every American right around their 65th birthday. A card arrives in the mail, red, white, and blue. Your name printed right there on the front, and you feel something you haven't felt in a long time. Relief. After a lifetime of premiums and deductibles and fighting with insurance companies, you're finally covered. The government's got you now. I want to be careful how I say this next part, because I'm not here to scare you. Medicare is a genuinely good program. It has kept generations of Americans out of bankruptcy, and I'd have defended to anybody. But that card in your wallet does not cover everything. Not close. And the gaps in it aren't small print or obscure edge cases. They are some of the largest, most common, most predictable bills of your entire later life. And they land on people who had no idea they were coming. That's the word I keep hearing from folks who've been through it. Blindsided. So today I want to walk you through 5 bills Medicare does not cover. Real ones. Common ones. Expensive ones. I'll tell you exactly what each one costs in today's dollars, why the gap exists, and what you can actually do about it. And I'm going to explain every bit of it in plain English, because the jargon around this stuff is genuinely awful, and I think it's part of why so many people get caught. Stay with me all the way to the end, because number 5 is the big one. It's the single most expensive thing that can happen to a retiree in America. It can consume everything you spent 40 years building, and Medicare doesn't pay a dime of it. And number 3 is the sneakiest thing in this entire program. A situation where you can lie in a hospital bed for 5 days, in a gown, hooked to an IV, with nurses checking on you every hour, and still not qualify for the coverage you think you have. Let me give you a couple to walk through this with. Call them Jim and Barbara. They're not real people. They're a stand-in for a lot of you. Early 70s, both on Medicare, careful with money their whole lives, and both absolutely certain that once they got that card, the healthcare part of retirement was handled. Let's see what actually happened to them. Let's start with the one that catches people first, because it shows up early and it never stops. Medicare does not cover routine dental, vision, or hearing care. The big 3. And I mean, it doesn't cover them at all. Not partially. Not with a copay. Original Medicare will not pay for a cleaning. It won't pay for a filling, an extraction, a root canal, a crown, dentures, or an implant. It won't pay for the eye exam you get to update your glasses prescription. And it won't pay for the glasses. And it will not pay for hearing aids, or even for the exam to fit them. Now let me tell you why. Because the reason is genuinely interesting and it explains an awful lot about this whole video. Medicare was written in 1965, and the people who wrote it built it to cover what they thought of as medical care, illness and injury, the heart attack, the broken hip, the surgery, teeth and eyes and ears got filed under something more like routine maintenance, the way you'd think about getting your oil changed. So they were written out of the law from the very beginning. 60 years later, they're still out. This isn't a case-by-case judgment call by some clerk. It's structural. Those categories were excluded on purpose, in the original design, and they've never been let back in. Here's what that costs you today. A routine cleaning and exam runs about $200 to $350, twice a year, forever. A single crown, $1,000 to $1,700. A full set of dentures, $1,500 to $3,500 per arch. So if you need top and bottom, double it. A dental implant, $3,000 to $6,000. And hearing aids commonly run several $1,000s for a pair, and they need replacing every few years. So picture Barbara. Barbara had a rough year with her teeth, a crown that failed, a root canal, and eventually a partial denture. Nothing exotic, nothing anybody would call optional. She wrote checks for about $6,000 over 11 months, and Medicare paid exactly nothing toward any of it. She kept waiting for a statement to show up saying it was covered. It never came. And this is far from rare. According to the government's own figures, nearly half of all Medicare beneficiaries have no dental coverage at all. And roughly 30% have untreated tooth decay. Untreated. Not because they don't care about their teeth, because they can't afford the bill and nobody's helping. And that matters for more than your smile. Poor oral health is linked to heart disease, to diabetes complications, to respiratory illness, so this isn't cosmetic. It's a health problem the program simply refuses to see. Now, let me be fair, because there are some narrow exceptions and you should know them. Medicare will cover dental work when it's directly tied to a covered medical procedure. jaw reconstruction after an accident, or dental clearance required before heart valve surgery. On the vision side, Medicare does cover treatment for actual medical eye conditions like glaucoma and macular degeneration, and it covers cataract surgery. And here's a nice little quirk almost nobody knows. After cataract surgery with a standard lens implant, Medicare will pay for one pair of glasses or one set of contacts. That's the one time Medicare buys you glasses. And on hearing, if your doctor orders a diagnostic hearing exam to figure out what's wrong, Part B covers that. It just won't cover the device that fixes it. So what do you actually do? A few options. Some Medicare Advantage plans bundle in dental, vision, and hearing. That's their big selling point, and for a lot of people it's genuinely useful. But read the details, because those benefits often come with annual maximums that are far lower than a real dental year costs. A plan might cap dental at $1,000 or $1,500, which doesn't go far against a $6,000 problem. You can buy standalone dental insurance, but watch for waiting periods and annual caps there too. Dental schools in most metro areas do excellent work at a fraction of the price, supervised by faculty. And since 2022, hearing aids have been available over the counter without a prescription, which has brought some options down dramatically in price. And one more thing, honestly. For many people, the smartest move is simply to budget for this. Set money aside every year, on purpose the way you'd budget for property tax. Because this bill is coming. All right, number 2, and this one is structural, and I'd argue it's the most important thing in this entire video that nobody tells you. Here's what most people believe. Medicare Part B, that's your doctor and outpatient coverage, pays 80% and you pay 20%. And that's true. But here's the part that should stop you cold. There is no ceiling on your 20%. None. Let me say that again because I want it to land. Original Medicare has no annual out-of-pocket maximum. There is no cap, no stop loss, no point at which the program says, all right, you've paid enough this year, we'll take it from here. That 20% just keeps going and going for as long as you need care. Now think about every insurance plan you had during your working life. Every single one of them had a maximum. There was a number, 5,000, 8,000, whatever it was, and once you hit it, the plan covered everything for the rest of the year. That number was the thing that stood between you and financial ruin. And the day you turned 65 and moved on to original Medicare, that protection quietly disappeared. Nobody mentioned it. There was no warning letter. You just walked from a world with a ceiling into a world without one, and you almost certainly didn't notice. Do the arithmetic on what that means. 20% sounds modest. 20% of a $500 visit is $100. Fine. But 20% of a $200,000 year, a serious cancer, a complicated surgery, a long fight, is $40,000. Out of your pocket. And if the next year is just as bad, it's another $40,000. There's nothing in the program to stop it. And there's a second piece of this that ambushes people, so let me explain it. Your hospital coverage, Part A, has a deductible. In 2026, it's $1,736. Most folks assume that's a once-a-year thing, like every deductible they've ever had. It isn't. It's per benefit period. And a benefit period isn't a calendar year. It starts when you go into the hospital, and it ends after you've been out for 60 days. So if you're hospitalized in February, get out and land back in the hospital in July. That's 2 benefit periods, and you owe that deductible twice. In a bad year, you could owe it 3 times. Same year, same person. This is what happened to Jim. Jim had a genuinely difficult year. A procedure, a complication, a second stay, and the 20% and the deductibles just kept stacking up, one after another, with no wall to stop them. Jim wasn't unlucky in some exotic way. He was just sick, in a program with no ceiling. So what's the fix? This is the whole reason the 2 big roads exist. If you're on original Medicare, you buy a supplement. That's Medigap, a private policy that pays those gaps for you and effectively builds the ceiling the government never gave you. If you go the Medicare Advantage route instead, those plans are legally required to have an out-of-pocket maximum. In 2026, it can run as high as about $9,250. For in-network care, that's real money, but it's a wall. It stops somewhere. Original Medicare, all by itself, does not. And let me give you a genuine piece of good news, because it's the biggest improvement to this program in years, and it deserves to be said. Your prescription drug coverage, Part D, now has a hard annual cap. As of 2026, once your out-of-pocket drug spending hits $2,100, you pay nothing more for the rest of the year. Nothing. For people with expensive medications, that is genuinely life-changing, and it's brand new. So the program does move. It just moves slowly, and it hasn't moved on that 20%. Now number 3. This is the sneaky one, the one I promised. And it's sneaky because you can do everything right and still get caught. First, let me tell you what Medicare actually covers for a nursing facility, because there's real coverage here and it's worth understanding. If you need short-term skilled care after a hospital stay, rehab after a hip replacement, say Medicare will cover it. Days 1 through 20 you pay nothing. Days 21 through 100 you pay $217 a day in 2026. And after day 100, Medicare pays zero. The coverage simply ends. That's the first thing to know. Even in the best case, this is a 100-day program, not a long-term one. But here's the catch that makes it all fall apart. To get any of that coverage, you must first have what Medicare calls a qualifying hospital stay, at least 3 consecutive days as an inpatient. And that word, inpatient, is doing enormous work in that sentence. Because here's the thing almost nobody understands. Being in a hospital and being admitted to a hospital are two completely different things. You can be wheeled in through the emergency room, put in a hospital bed, in a hospital gown, hooked up to an IV, with nurses checking your vitals all night, for days, and still be classified as an outpatient. The hospital calls it observation status. An observation status is an outpatient category. Your status doesn't depend on the bed you're in or how sick you feel. It depends entirely on whether a doctor wrote an admission order on your chart. And observation days do not count toward that 3-day inpatient requirement. Not one of them, time in the emergency room, doesn't count either. And the day you're discharged doesn't count. So run the scenario. Jim falls. He's taken to the hospital. He's there 5 days. 5 days in a bed being cared for around the clock. He's discharged to a rehab facility because he can't safely go home yet. And then the bill comes, and it's the whole bill because those 5 days were classified as observation. He was never technically admitted, so he never had a qualifying stay. So Medicare's skilled nursing coverage never switched on. Jim was physically in a hospital for 5 days, and in the eyes of the program, he never went to the hospital at all. It gets worse. During an observation stay, Medicare Part B, the outpatient side, handles your care, which means you owe that Part B deductible, which is $283 in 2026, plus 20% of every single service. And here's the insult. The routine medications you take at home every day, your blood pressure pill, your diabetes medication, aren't covered under Part B in that setting. The hospital can bill you directly for them, at hospital prices. People have gotten bills for their own pills. Why does this happen? There's a rule called the 2 midnight rule. Broadly, if the doctor expects you'll need hospital care spanning at least 2 midnights, you should be admitted as an inpatient. If not, you're observation. It sounds simple, but it's a judgment call. Hospitals face real pressure around how these get classified, and the decision gets made without your input, often without anybody telling you at all. So, here's what to actually do, and this may be the single most valuable thing in this video. Ask. Every single day, out loud, to the doctor, on rounds. Am I an inpatient or am I on observation? And if they say inpatient, ask them to point to the admission order. Then, before discharge, ask this. How many inpatient days count toward the 3-day skilled nursing rule, and does this stay qualify? Get the answer in writing if you can. Do not wait until discharge day to ask, because by then the problem has already happened. There is a notice involved. If you're on observation for more than 24 hours, the hospital is required to give you something called a Medicare Outpatient Observation Notice, usually within 36 hours. Read it. It's often the first written warning that you're headed for this trap. But understand, it's just a notice. It doesn't change your status. It just tells you what your status is. And know that you have appeal rights. A federal court case established that patients can appeal these status decisions, and there's now a process for it. So if you get hit with a nursing home bill after an observation stay, Do not treat that bill as final. Gather your dates, your notices, your records, and appeal. People win these. One more thing worth knowing: Medicare Advantage plans often waive that 3-day requirement entirely. Most of them do. That's a genuine point in their favor, and if you're on one, call and ask. There are also certain doctor groups with waivers, so the trap isn't universal, but if you're on original Medicare, it's very real. Number 4. This one has a beginning and an end you can see clearly. Medicare stops at the border. If you leave the United States and you get sick, Medicare almost certainly will not pay. Not in Italy, not in Mexico, not on a cruise. It's not a coverage detail, it's a geographic wall. The program was designed to pay American providers under American rules, and outside that, it just doesn't function. There are a few narrow exceptions, and they're genuinely narrow. Certain emergencies when you're closer to a foreign hospital than an American one, some situations traveling through Canada, and care on a ship within 6 hours of a U.S. port. That's about it. Do not plan a trip around those exceptions. So picture Jim and Barbara doing the thing everybody dreams about, the big trip to Europe they saved for their whole lives. And Barbara has a gallbladder attack in a foreign hospital. Surgery. 4 nights. And the bill is theirs. All of it. And if something more serious had happened, if she'd needed to be flown home on a medical evacuation flight, those routinely run into 6 figures. $100,000 is not an unusual number for a medical evacuation. Medicare pays none of it. Here's the good news, and it's cheap and easy. First, some Medigap supplement plans, the ones lettered C, D, F, G, M, and N, include foreign travel emergency coverage. They'll pay 80% of emergency care abroad after a $250 deductible. But, and this matters, there's a $50,000 lifetime maximum on that benefit. Lifetime. Not per trip. Not per year. That's a real help against a gallbladder, and it is not going to save you from a catastrophe. Second, and this is the real answer, buy travel medical insurance for every single international trip. Not trip cancellation, travel medical, and specifically look for one that includes medical evacuation. It costs a fraction of what people expect, often less than a nice dinner out for a whole trip's coverage. And it's the difference between an inconvenience and a financial catastrophe. And if you're on a Medicare Advantage plan, check before you go. Those plans rarely cover foreign care. This is genuinely one of the easiest problems on this list to solve. It's a small check, written before you leave. Most people just never think to write it. And now, number 5. The big one. The one I promised would stop you cold, and it's the biggest financial risk in American retirement. Bar none. Medicare does not cover long-term care. Let me define that clearly, because the confusion here is the whole problem. Medicare pays for what's called skilled care, care that requires a nurse or a therapist, aimed at helping you recover. Rehab after surgery. Wound care, physical therapy after a stroke. That's covered, at least for a while. But long-term care is something different. The technical name is custodial care, and it means help with the ordinary business of living: bathing, dressing, eating, using the bathroom, getting from the bed to the chair. That's not medical treatment in Medicare's eyes. It's just help. And Medicare does not pay for help. Sit with how strange that line is. If you need a nurse to change a dressing, that's covered. If you need a person to help you into the shower every morning for the next 4 years, that's on you. The distinction isn't about how much you need it or how much it costs, or whether you can possibly manage without it. It's about whether you're getting better. If you're recovering, Medicare's interested. If you've simply grown old and need a hand, it isn't. And this is not a rare situation. Roughly 7 out of 10 people turning 65 today will need some form of long-term care in their lives. 7 out of 10. This isn't the exception. It's the expectation. So here's what it costs, and these are the current national numbers. A private room in a nursing home now runs about $355 a day. That's $129,575 a year. A semi-private room, that's with a roommate, is about $315 a year. Assisted living, which is a lighter level of care, has a median around $6,200 a month, about $74,000 a year. Memory care for dementia runs higher, often around $90,000 a year and up, and bringing help into your own home runs somewhere around $34 an hour. which for full-time care lands in the same neighborhood. $6,000 or $7,000 a month. Those are national medians, by the way. In high-cost states, it's dramatically worse. In Alaska, nursing home care can run $300,000 a year and up. And one analysis found that a 65-year-old today would need to set aside about $135,000 just to cover their average expected lifetime long-term care costs. Average, meaning half of people will need more than that. Now let me close off the escape hatches, because people always ask, does Medigap cover it? No. Your supplement fills the gaps in Medicare it doesn't add a benefit Medicare never had. Does Medicare Advantage cover it? Some plans have started adding small supports, but nothing remotely on the scale of a nursing home bill. So the answer for all practical purposes is, nobody's coming. You pay. And here's what actually happens to most families, and it's grim. So I'm going to say it plainly. You pay out of pocket from your savings until the savings are gone. And when they're gone, when you've spent down almost everything you own, Medicaid takes over. That's the program for people with very little, and it is today the single largest payer of nursing home care in America. Roughly 2/3 of nursing home residents are on it. But to qualify, you generally have to be down to almost nothing. In many states, around $2,000 in countable assets. And there's a 5-year look-back, meaning they'll examine everything you gave away in the previous 5 years, so you can't simply hand your money to the kids when the diagnosis comes. That's the actual American long-term care system. Spend everything, then qualify for the safety net. That's what happened to Jim and Barbara's mother, a lifetime of careful saving gone in about 2.5 years of memory care, and the family sat there stunned because they'd assumed Medicare would handle it, the way it had handled her hospital stays. So what do you actually do? There's no perfect answer, but there are real options, and the worst thing you can do is nothing. Long-term care insurance exists, and it's the direct solution, but it's expensive. And the classic use it or lose it policies frustrate people, which is why hybrid policies have gotten popular. Those combine life insurance with a long-term care benefit, so if you never need care, your family still gets something. Those are worth looking at, and you want to look while you're healthy, because you can't buy this once you need it. That door closes. You can earmark a specific chunk of your savings for care, on purpose, and mentally wall it off from your spending money. You can plan around home equity. The house is often the largest asset a family has, and it very frequently ends up being what funds care. If you're a veteran or the surviving spouse of one, look hard at the VA's aid and attendance benefit, which pays a meaningful monthly amount and is chronically underclaimed. People simply don't know it exists. And you can learn how Medicaid actually works in your state well before you need it, because the rules are strict and the planning takes years. And you can do the simplest, hardest thing. Talk to your family about it, out loud, before the crisis. Who would help? For how long? At what cost to their own life and job? That conversation had over a kitchen table at 70 is worth more than any policy you'll ever buy. So let's line them up, because together these 5 are really one checklist. 1. Routine dental, vision, and hearing. Excluded since 1965, and it never stops costing you. 2. The 20% with no ceiling. Original Medicare has no out-of-pocket cap, and the Part A deductible can hit you more than once in a year. 3. Skilled nursing beyond 100 days, and the observation trap that can void that coverage entirely, no matter how long you were lying in that bed. 4. Care outside the United States. Medicare stops at the border. And 5. Long-term care, the biggest bill of your life, and the program doesn't touch it. Now let me give you the honest picture, because I don't want you to walk away frightened, and I don't want you to walk away thinking I'm knocking the program. Most of what's on this list has a solution, and the solutions are not exotic. 2 of these 5 holes, the 20% and a piece of the travel gap, get largely closed by a Medigap supplement. 2 others, dental, vision, hearing, and the out-of-pocket cap, get partly addressed by Medicare Advantage. Neither road is better than the other. They're different trades, and we've talked about that on this channel before. What matters is knowing which holes your particular setup leaves open. But here's the sentence I most want you to remember. Neither road covers long-term care. Not Medigap. Not Advantage. That one is on you no matter what you choose. And it's the biggest one of all. If you take a single action after this video, let it be to make an actual plan for that. And let me say the fair thing about Medicare itself. It covers something like 69 million Americans. It has kept generations of retirees out of poverty and out of bankruptcy. Before it existed, growing old and getting sick in America meant for an awful lot of people going broke. That's not a small thing, and I won't pretend otherwise. Medicare isn't a scam, and it isn't broken. It's just incomplete. And it's incomplete in ways it was designed to be 60 years ago by people making reasonable decisions for a world that no longer exists. Because that's really the story underneath all five of these. When Medicare was written in 1965, the average 65-year-old didn't live all that many more years. The program was built to handle acute illness, the heart attack, the broken hip, the surgery, the thing that either killed you or you got over. It was never designed for the slow, grinding, expensive business of growing very old. Teeth, eyes, ears, and long-term care were all left out at the beginning because they weren't the problem the program was solving. And then we did something remarkable. We added decades to human life. We turned old age from a short chapter into a long one. And in doing that, we made the biggest expenses of later life precisely the ones Medicare was never built to cover. That's the gap. It didn't appear because anyone did anything wrong. It appeared because the world changed and the law mostly didn't. There used to be a patch for it, too, and it's worth remembering. A generation ago, most large employers sent their retirees into Medicare with a company health plan, riding alongside it, filling the holes. 2 out of 3 big companies did that in the late 80s. Today it's down around 1 in 4, and in the private sector it's nearly extinct. So the gaps didn't just stay open, the thing that used to cover them quietly went away, and today's retiree stands in front of those holes alone. So here's where I'll leave you. That red, white, and blue card in your wallet is a good card. It's a genuinely good card, and you earned it, and it will carry you through most of what comes. It just isn't a complete one, and the difference between those two things is the whole subject of this video. You don't have to be frightened of these 5 bills. You just have to see them coming. Know that the dental and hearing money is going to be spent, so budget for it instead of being ambushed by it. Get the ceiling that Medicare doesn't give you through a supplement or a plan with a cap. Ask the word inpatient out loud every single day if you or someone you love is ever in a hospital bed. Write the small check for travel medical insurance before every trip, and make a real deliberate plan for long-term care while you're healthy and you still have every option open. And you don't have to figure any of this out alone. Every state has free Medicare counselors who don't sell anything and don't earn a commission on your decision. That's the SHIP program. And they're genuinely good. Medicare's own helpline is open around the clock. An hour with the right person at the right moment can be worth more than almost any investment you'll ever make. Because a blind side only works if you don't see it coming. And now you do.